I'd like to call to order the Group Insurance Committee meeting for Wednesday, January 26, 2022 at 4:02 in the afternoon. First order of business is a roll call.
Okay, Jeff Baza.
Present.
Okay. Eric Diamond.
Present.
Mike Dixon.
Present.
Rachel Drake.
Present.
Serena LaRue Hatch. Absent. Diane Lyon. Absent. Tony McMillan.
Present.
Tony Moresco. Absent. Don Echeverry.
Here.
And Robert Munson here. Okay, we have a quorum.
Thank you. Please mark anybody present as they come in to the meeting. Moving on to public comment. Do we have any public comment? Nobody's filled out a card. Okay, it's a pretty empty room. 2.01, approval of the minutes for the December 15th, 2021 meeting of the group insurance. They're on the board and you should have received them in your email yesterday. So if you've read them, I'm looking for a motion to approve.
Jeff Balzo will motion to approve.
Rachel Drake, second.
Okay. We have a motion by Jeff and a second by Rachel. All those in favor, please signify by saying aye.
Aye.
Opposed? Motion passes. 2.02, presentation and discussion of the Washoe County School District Group Insurance Claims Experience Report as of December 2021. This is for information discussion only. Welcome, Lloyd.
Good afternoon. Lloyd Barnes, LP Insurance Services. Good to see everyone in the new year. Okay, so let's talk about the full 12-month year-end claims report. Going to Exhibit 1, as you can see there on our summary page, you can see the enrollment counts on line 1 for the year were down about 3.5%, hovering in around 7,100. Dependent unit counts down a bit and total dependents down a little bit, as expected. The net paid claims on line 4 ended up about 14.5% higher than last year at $5.6 million on average per month. With that yields a composite cost of $786.62 compared to $662 last year, so up about 18, almost 19%. Fixed costs, as we would hope, are pretty flat at $418,000 a month for a total plan cost of $6,027,726 on average versus $5.3 million, up about 13%. Yielding a composite cost of $845.38 versus $719.60, up about 17%. For the large claimants, started out slow, but we certainly caught up and actually exceeded the 2020 plan year with 28 claimants greater than the $200,000 level. So that was a fairly sizable number from that standpoint. Over on the right, just I won't dive too deep into this, but you can see there that the composite cost for the PPO plan was up about 19%, and the composite cost for the HSA plan up quite a bit as well. Going to Exhibit 2, which is our graph. This is one of those, I think, Nevada graphs where you wait a couple months and the weather changes. This is sort of similar. We waited a few months, and unfortunately, the cost did spike up and have somewhat stayed there for the last few months. And so we're averaging quite a bit higher, certainly quite a bit higher than 2020, as we know, and quite a bit higher than previous years. And this is something that, as we've talked about, we were sort of anticipating. It went up a little higher and a little bit more aggressive than I think we were hoping. But we are seeing this somewhat across the board with a lot of our self-funded clients, in that the inflationary pressures of everyone coming back into the system, getting care, has certainly put pressure on the cost structures for most health plans. Like I said, I think yours is a little bit higher than what we are seeing, but given how low 2020 was, it's a little bit hard to compare to 2020, but as such, we are seeing that 18, 19% inflationary cost for your plan.
Jeff, did you have a question?
I did, but Lloyd answered it. He must have knew what I was going to
I
ask.
did. I was reading your mind, Jeff. Okay, so Exhibit 3, was where we go into the detail of the all plans combined. So I'll just sort of focus in on that December column because we have seen the previous months. As you can see there, the enrollment counts have been pretty stable, although, as I said, down a bit for the year over year. Going down to line 30, you can see there the total claims for the month, 6.9 million. I was going to cough at that one too, Laura. Thank you. And fixed costs, as we talked about, are fairly stable at the 415. So all in all, it was actually the highest expense month you had for the year at 1,040.68, and quite a bit higher than this year's average as well as last year's average on the far right there. And this too has been somewhat of a trend that we're seeing with our other plans, is that sort of this last quarter of the year, costs definitely seem to elevate. So we're all sort of holding our breath for what the first part of 2022 starts to look like as we start to get those claims into the system. We're hopeful that things subside a little bit, especially as we get into new deductible years. People hopefully got it out of their system, so to speak, and we can see things normalize a little bit as we move into the new year. But all in all, it was a big cost plan year, and that was something that we've sort of been talking about for some time. Let's see. I'm going to go to Exhibit 6. I'm sorry. No, I think that was the last one I wanted to cover from that standpoint. Exhibit 4 and Exhibit 5 are the active and retirees. I'll let you peruse those at your leisure. Exhibit 6 and 7, 8. Let's move on to the large claims information on Exhibit 12, please. It's where you can see that 28 employee count of large claims over the $200,000 level. And I did want to spend a little bit of time here just because we are seeing certainly an increased influx, not only on your plan but other plans, of these larger claims. Again, we track on your plan, we start tracking at 212,000. They actually start to hit this report based on your stop loss level. But this has been something, again, for a lot of plans, we're seeing a lot more of these large claims, catastrophic claims, whatever you want to call them, within plans. Some of that still is predicted to be based on people not getting some of the care they maybe should have during 2020. But it's also just a lot of prescription drug costs. As I know you're aware, that a large specialty meds are still driving a lot of costs, and we're just seeing generally a lot of increased utilization for chronic conditions. On the next exhibit, Exhibit 13, fortunately the plan didn't have a lot of the extremely large cases, which is sort of a double-edged sword because you end up not getting the reimbursement from your stop-loss carrier if a bunch of them just stay just under that stop-loss deductible amount. But you did have a few claims that exceeded the $425,000 there, so you can see that. So that will all reset as we get into January, and we'll start tracking and looking at it all again for next year or this year. Questions that I could answer?
Can I ask a question on that slide?
Yes, please.
The last slide, when I was looking at that yesterday, I was wondering vaguely, can you give some examples of what puts people at such a high, when you talk about the 28 people that went over that 212,000, I know you just mentioned some pharmaceutical type stuff, but I read through it, it caught my attention too that some of the 28 are subscribers and some are also dependents. So I'm just curious, what are some, do we know, like what, I mean, I think of that kind of money, I'm like, are those severe cancer cases? What are we supporting?
It's a good question. We actually get quite a bit of detail from Anthem on your large claims and what their diagnosis is and what's going on with them. And these can be everything from premature babies to cancer claims to the very high cost specialty medications. Those are pretty commonly what they're gonna live in some of those categories, but you'd be surprised. You end up in the hospital for 30 days, you're gonna hit this list, or even in many cases 15, 20 days, you'll start to hit these lists. So it can certainly run the gamut, but cancers have been areas that you've had some challenges in. The high cost medications have been a couple other areas. We certainly can pull some of the more detail if you'd like, or we can Laura can share that as we've gone through this recently with her as well. So
hepatic failure, so organ failure as well. So major ongoing illnesses that we're seeing on that large claim report.
Thank you, Kelly.
The voice from above.
I know, I was like, also there was a voice in there.
Thank you, Kelly.
I think Jeff has a question.
Yes. Lloyd, as always, thanks for the explanation on these large claims. Before previous meetings, we've talked about lasered claims, and those are ones that aren't going to be covered by stop loss insurance. So if we have any of those expensive or specialty meds, then are those not going to be picked up in 2022? Would they be lasered?
Good question. And what Jeff's referring to is in the stop loss policy that you buy, the district buys to protect the plan. It is meant to cover unexpected expenses that happen. Basically, a cancer pops up, someone experiences cancer. Where things get tricky in the world of stop loss is when you have claims or cases or individuals that are going to have ongoing expenses. Insurance companies are very good and comfortable with writing unknown risk, but when it comes to known risk, if the house is going to burn down next week, most insurance companies are going to say, well, I'm not going to insure that house for the amount that it's going to cost to rebuild it. Similarly, in healthcare and stop loss, if someone has an ongoing claim that is going to exceed your specific deductible amount of $425,000 into the future, it's very common for the insurance company to say, well, we're not comfortable insuring it except above whatever amount we think it's actually going to be. So if there's a claim that an insurance company, the stop loss carrier, thinks maybe is going to be $500,000, they might put what we call a laser, as Jeff referred to, on that claim and say, well, we'll cover it for that person, we'll cover it only for anything over $500,000 instead of $425,000. And so those do occur here and there. I don't have that information directly in front of me, Jeff, but I don't believe your policy for 2022 has any lasers on it. Laura, do you recall by any chance on that? But I don't believe that there were any lasers that hit for this year.
There are no lasers for 2022.
So at this point, none of these claims were of a nature that the insurance company felt that they needed to laser it, or that it was going to be ongoing at an amount above what your current deductible was.
Okay, great. Thank you.
Robert?
But it is my understanding all of those go back to zero, so they will start fresh. So even if it was at 400,000, it's going to start at zero, and it would have to hit that stop loss amount again before it would go to stop loss. So,
Correct.
And some of those might be continuing at high levels, and some of them might be maintaining. So who knows?
Yep, very good point.
Any more questions? No? Okay,
Thank you.
thank you. Number 2.03, the representative from Anthem to do the activity is not here, so we're going to just move on in our agenda, and if Pam comes in, then we'll go back to it.
I think Kelly's.
Oh, Kelly is gonna do it? Okay.
Yes.
I'm sorry.
Voice from above.
Kelly's gonna do it, okay.
For the record, Kelly Dvorak with Anthem. Hello, everybody. Sorry we couldn't be there in person, but nice to see you all. You're really, really tiny in my screens. Thanks for pulling this up, Veronica. This is the turnaround report for claims. We are looking, I believe, at medical here first. On the far right-hand side, you will see the December column, which is where we're focusing. Total claims received for both plans was 14,624 claims for the month. In the first, 14 days, we had 99% of those claims paid. All of them were paid within the first 60 days. So nothing aged over that 60-day time period. You can see the totals for the year in the very far column. All of the claims were paid within 60 days. We didn't have anything age beyond that. You can see in the bottom pended in the kind of peach color, 60 and 90 days. We didn't have any claims over that time period. So that's for the total medical. Any questions on that?
I'm not seeing any.
Perfect. And then we have the breakdown of the PPO and the HSAs plans. Next PPO, again, 12,000 of the 14,000 claims came in for that plan. We had all of the claims paid within the 60 days on this one. And for the HSA, all of the claims again were paid within 30 days on this one. So we didn't have any age on the HSA plan beyond the 30 days. And I skipped it, but up at the very top, the light blue, the RX claims, we had 7,400 RX claims, 8833 for December, and the average was 74 per month for a total claims for 2021 of just over 89,000. Perfect. We can move on to dental if there's no questions.
Go ahead.
Awesome. And then again, far right-hand side, looking at the month of December, 1,917 dental claims that came in. We had 95% of those paid in the first 14 days. And then the rest of those 4.5% claims were paid in 30 days. So no claims that aged beyond the 30-day window.
Any questions for Kelly on that? Okay. Thank you. All right. 2.04, presentation discussion of the Washoe County School District Group Insurance Wellness Program reported to cover current events and programs as of December 2021. This is for information and discussion only.
Okay, Laura Thurston for the record. As you know, our health assessment deadline was December 1st, and we ended the year as of December 31st with a little over 88% of our members who had completed the health assessment. And just a reminder that if people have not completed their health assessment, they can still complete their health assessment and stop or continue their discount going forward after that. So vaccinations, I was able to get our total vaccinations at our screening events. So this is just screening events, just as a reminder. Other vaccinations, of course, go through our claims through pharmacies and other doctor appointments. So we had a total of 890 vaccinations at our screening events. Our screening events were at Specialty Health along with the wellness screenings. And then we had two short challenges through Virgin Pulse. We had the Appreciate Others Challenge in December where we had 245 participants, and we also have the Lean on Me Healthy Habits Challenge that just ended January 15th, and we had 198 participants in that. And I guess it's not necessarily on here, but we are planning a mindfulness step challenge coming up in the spring here soon. So you'll be seeing that, probably more information on that next month.
Any questions regarding wellness? Thank you for the report. All right. So moving on to all the stuff we really were coming here for today, right? That we've asked these were requests from members of our committee. So the first one, 2.05, presentation and discussion of the Washoe County School District Group Insurance Pharmacy and Anthem Formulary Review. This is for information and discussion only. And am I turning it to Kelly? Or
Yes, I will. I will introduce. I will introduce Bridget, who's actually going to be walking through this portion for our specific pharmacy discussion and questions. Bridget, I don't know if you were going to share your screen. It looks like you are. That's perfect. So you'll be able to drive. I'll shut up. You don't have to hear from me for a little while. So go ahead, Bridget, take it away.
All right, thanks, Kelly. Hello, everyone. I am also very sad that we're not there because I was going to go skiing while I was there. So that's a bummer. I'm sure we're in Colorado, so I'm sure we will get our opportunity here. So, all right, so we're going to talk a little bit tonight about, first, we're going to talk about the process by which we develop our drug list, because there's a lot that goes on kind of behind the scenes, both internally and with some external folks. So we'll talk a little bit about that process and really why it's important. And then we'll also look specifically at some Washoe County School District data to kind of wrap it all up. And so you can see, you know, how it kind of comes out practically speaking, right? So we're going to focus on diabetes quite a bit because I think that was the ask from the group. And also it's a excuse me, it's a pretty high spend category. So it is important for you guys to understand, you know, why we cover the drugs that we do and vice versa. So, all right, goodness, now I need to make sure I know how to work the controls here. There we go. Okay. So this slide really lays out a lot of the elements that go into developing the drug list. So, but really the key points to keep in mind are at the top. So when we talk about the Pharmacy and Therapeutics Committee or the P&T Committee, that's really the committee that looks at the clinical data, right? So you've got, we've got an internal team actually that looks at the trials for the drugs, we look at guidelines, we get provider feedback, and we take all of that information and we roll it up into a drug review or drug monograph. And then we present that to that committee. And what's really important, again, to remember about that committee is it's not internal folks that work for Anthem or IngenioRx. These are external, usually providers of care out in the community, well, out in across the nation and the states that we serve. But these are the folks that are actually using the drugs. They understand how they work and what patients they work best in. And so as we're presenting that information, you know, they're using their own clinical practice experience to help us make decisions. And so when they are able to, when they actually make the decisions, then based on our recommendations, we're beholden to those decisions. So if they say, you know what, we think this drug works better than this drug, then we have to adjust the drug list accordingly and cover the drugs that they think work better, have better outcomes or whatever first. So that's a really important point. Give me just a second. Sorry, my mouth is really dry. Okay. So second important point is that, obviously we're looking at cost. We want to make sure that we have a cost-effective formulary, but we're only going to prefer low-cost drugs if they're similar and have the same quality as far as outcomes, and when we're talking safety, efficacy, all of that stuff. So there are situations where we might actually cover a higher cost drug, a brand name drug, or something like that, if we feel like that drug actually has a better safety profile or works better, or down the road actually, prevents a costly or concerning outcome. So that's another thing to really keep in mind. So we look at that clinical first, then we look at the cost second. But again, cost only comes in terms of, drugs that we think already are similar. When we looked at them clinically, they're similar as far as safety, efficacy. Those are usually what we're talking about. And then we make the kind of financial decisions. And so that's really that number 2, that value assessment committee. Now, those are internal Anthem and GenieRx folks. And these are the folks that are going to look at, again, they're going to look at modeling. They're going to look at, what our current utilization of a medication is before we make any changes, or all of those things that go into how we actually create the formulary. So what tier it's on, whether it has prior authorization, and all of those other elements of drug management. So the more kind of financial aspects. And then we also are looking at the pipeline. So that's another really key point. So, we need to know what's coming up. We need to know what's kind of out there in the evidence, what's being studied, what's close to approval, because, obviously we want to be ready to go when that drug actually hits the market. So, if you think back to, a few years ago when everybody was kind of concerned about hepatitis C, we had these really expensive medications coming out. And, we wanted to make sure they were being utilized in the right patients. We actually had all of that ready to go. We looked at our criteria, we had those approved, and everything was ready to go the day the drugs hit the market. So that's really important because there's not that lag time there, right? Where we might not have prior authorization in place yet for these new drugs. And so, we're not able to manage them like we would like to. So that's a really important piece of what this whole process contains too. Just a couple other things to point out on this specific slide. I do want to call your attention to the fact that we have one Pharmacy and Therapeutics Committee that looks at all drugs across the board. So they're looking at both medical drugs and drugs that go under the pharmacy benefit. So that's really, really important because, we have one team that's making those decisions, but then also if we decide to put prior auth in place, those criteria are aligned across both of those benefits. So, that causes less member abrasion and provider confusion and all those other things, that can go into, well, am I getting it under the pharmacy benefit or am I getting it under the medical benefit? So that's a really important point too. And then just really overall, again, to kind of call your attention back to the fact that, we're looking at overall health, right? So sometimes to provide better overall health or better overall costs, we actually have to pay for more expensive drugs kind of upfront to make that happen. So that's the kind of philosophy that we have underneath all of our formulary development. And then just the last thing I'll say on this slide is that we do have several different formularies. We have different formularies in our Medicare business and our Medicaid business. And then for our commercial business, we have a couple of different options. We have specific formularies that are utilized in ACA compliant individual business that, that members might go through on an exchange or something like that. So we have a lot of different formularies, but it all starts with the same process. It all starts with the same clinical decisions. And then, the end product might look different depending on what we're trying to accomplish with that formulary, but it all starts in the same place. So that, that foundation is there for all of our drug lists. Okay, so speaking of drug lists, Washoe County School District is currently on our national drug list. This is our broadest formulary with the most options, so it provides the most choice. And there are just what we call a few closed drug classes. So what I mean by that is there's a few classes where we have some drugs that are non-formulary. Diabetes is a great example of that. We have lots of diabetes options. We have lots of options to treat patients. And so we really want to focus on those drugs where we feel like we have the best evidence that they're going to produce the best outcomes. And then the other drugs that we don't feel like are the same quality, those are non-formulary in those categories. So that's a one example of what we mean by closed drug classes. Okay. So let's look a little bit more specifically at diabetes and, why we might choose certain drugs over others and what some of those drug examples are. So when you think about why we treat diabetes, really what we're trying to do is we're trying to prevent the long-term complications that we can see with diabetes. So chronic kidney disease and heart attacks and strokes are probably the biggest ones. So when we have evidence for certain drugs that they actually prevent those long-term outcomes, like they actually reduce cardiovascular events and heart failure exacerbations, or they reduce hospitalizations, or whatever we might be looking at, those are the drugs we want to prefer, right? So again, even though they might be a little bit more expensive in the beginning, we're actually providing the best outcomes and the best overall cost kind of in the long run, right? So some of the drugs and some of the examples of where we do have some good evidence of those longer term outcomes are down here on this slide. And then another thing is we also have, if you look at the bottom, we have a couple classes where there's actually some safety concerns in some of these medications. So excuse me just a second. And so when we're looking at the safety, the drugs that we prefer on our formulary are the ones that have the safety profile that's a little bit better than some of the other ones. And so again, these are just a few examples. We do have one other preferred medication that's not listed on here, but then all of the other drugs that are in these classes, so SGLT2s, GLP-1s, and DPP-4s, all of the other drugs in those classes are non-formulary. Okay. One other place where we do direct members to a specific medication is in that very first, when they're first diagnosed, they're first starting medication. The guidelines clearly state that metformin is your first line therapy. It's inexpensive, it's relatively safe. There's a lot of people who can't tolerate it because it causes some gastrointestinal upset. But as far as some of the other concerns that we might see with some of the other drugs, like hypoglycemia, for instance, or some of the more concerning side effects with, say, some of the classes that you use down the line, metformin's relatively safe. And so it's recommended that everyone start there. That wasn't always the case, though. We had a class of medications called sulfonylureas, which the most common ones are glimepiride, glyburide, and glipizide. And don't ask me why they all start with G's. I don't know, but it certainly made it easier to remember them when I was in pharmacy school. So I'm not complaining necessarily. But we used to dispense a lot of that medication, a lot of those medications, and we don't so much anymore because of these updates to the guidelines. But we took it a step further because we really feel like metformin is the best option clinically, and we actually put a step edit in place in September of 2018 requiring that metformin has to go first. That's the case with the sulfonylureas, but it's also the case with some of those more expensive brand medications that we saw on the last slide too. They have to go with metformin first. That's what the guidelines say. That's where the evidence is. Then they can go, usually if they're going to progress, then they'll get add-on treatment with one of those other classes. Okay. I'm going to stop there. That was a lot of information. But before we dive into Washoe County specific data, do you guys have any questions on this piece?
Any questions? I have one.
Okay.
So since you talked about how you guys have vetted and looked through all the medications, when a provider prescribes a medication and you have something similar to it that you will cover, theirs isn't on the formulary, yours is, do you send them that information, or do they have to then go around and figure out which one is on the formulary?
That's a great question. And it really kind of depends on the touch points, right? So what would most commonly happen is the prescriber would write that, if they weren't familiar, say, with what we do and don't cover, we do have that out on the internet. So it is easily available to anyone. But of course, we know prescribers can't keep up with everyone's formularies, right? Because they're all a little different. So what would most commonly happen in that situation is a member would go to the pharmacy and it would reject at the pharmacy saying, either, try another medication or, whatever. I don't know exactly what the messaging is, but so we do rely a lot on our retail pharmacy partners to help with that sort of, triage, if you will. And so what they'll often do, depending on, again, what the reject is, because it might say, this drug requires a prior authorization. So it might just be that it might not be that it's not covered, but that they have to meet criteria to get it covered. And so a lot of times what will happen is that the pharmacist will actually reach out to the provider. So now, if the provider, say, would reach out to us, maybe say the member called their provider themselves and then the provider would reach out to us, then yes, we would walk them through what the options are. But I would say probably most commonly it's the touch point at the pharmacy and that retail pharmacist that's probably going to provide that information. Good question, though.
Okay, thank you, because that's one of the things we hear from members is that something got denied and then it's a big mystery until their doctor can figure out what will be covered. So I was just wondering if there was some way to help bridge that if you already know which one is the similar,
Yeah, and we do try to provide provider notifications, and they, like you said, we do send out a provider newsletter, which is primarily geared toward medical, but it also will note, when we have formulary changes and things like that. But again, we're relying on providers who are already overwhelmed. They already have, they may not even know what formulary to look at for what member. So we do, you're right, it is a challenge. But I think most commonly in that situation, the best thing to do would be to either for the member to contact their pharmacy and have them kind of help walk through like what their other options might be, or again, to call us. Because our customer service team would be happy to provide them the covered alternatives.
And this is Kelly, just to chime in. Additionally, I don't know if that was Dawn that was asking the question as well before, but we have a link to the national formulary. So that is something that if it has been provided, we can certainly provide. It's just a link that they can search a drug to see what tier it would be covered on for their plan. And then also, once folks get signed up for their Anthem.com or the Sydney, your drug list is automatically loaded on that back end. So let's say, my doctor's talked to me about maybe starting a new prescription. I would have that ability to go into the pharmacy tool online and actually search that drug to say, is this one covered? If it's not, if it says non-covered, it's going to give you an option to say, this one's not covered, but this one is at a tier 1 level. So there are some of those member tools that are out there. Again, I think in the heat of a medical diagnosis or trying to find, get a new script, folks are not obviously thinking through that, and that's completely okay. But if we can do some communication or education sort of prior to that, hopefully then that clicks and they say, oh, I know where I can go and look up that medication as well.
Thank you.
Yep.
Other
Thanks,
questions
Kelly.
Before we move forward? Okay, thank you. We can keep going.
Of course. All right. So, like I said, now we're going to look specifically at some of your data. This data is through, I believe, November. So when we're talking about current period, it's January through November of 2021 versus prior period would be January through November of 2020. So this is kind of small. I'm sorry about that. But that first metric there, the total pharmacy plan cost per member per month increased by just under 20%. So that's a pretty big increase. But again, kind of going back to the conversation we had earlier about claims, a lot of that is sort of an artifact of COVID, right? That's driving a lot of that increase because 2020 was abnormally low. So we know that. We know that a lot of that's being driven by specialty drugs. So a couple of your higher cost indications are cancer and inflammatory conditions. Inflammatory conditions are things like psoriasis, Crohn's, ulcerative colitis, rheumatoid arthritis. Those are kind of the big ones that fall under that bucket. But then, another kind of driver here in that higher cost is diabetes. It is the second highest indication by cost for your plan. So certainly something that's worth the time we're spending talking about it tonight. So let's talk a little bit more. Let's dive into a little bit more granular detail of what we're looking at. So diabetes is there on the second line. And so this graph has a lot of this table has a lot of information. It's got the number of prescriptions for each indication, the number of unique patients, then you've got your plan cost kind of in the middle. You've got how many were filled generic versus brand. And then you've got on the right-hand side there, you've got the prior period information and then the trend year over year. So if we look at diabetes there's 645 patients, which is about 7% of your overall patients that are using the pharmacy benefit. So asthma, let's look at asthma as another example. So asthma is about 13%. So lots more patients with asthma, right? But if you look at the cost of asthma versus diabetes, it's significantly more, in the neighborhood of $2 million more. And if you look at that on a per member basis, just taking that total and dividing it by how many patients you have, diabetes patients are over $4,000 per member for for an 11-month time period, so almost for a year. While asthma patients are $468. So again, you have more patients with asthma, but it's really to your benefit to kind of focus in and make sure that you're managing the diabetes spend right. Well, I mean, that we're helping you manage the diabetes spend right? So we talked about a lot of the tools that we already use to help you manage that spend. So formulary, step therapy, prior authorization, and all that, all of those things. So I will stop there. There's a lot of data on here. There's a lot of interesting data. But again, just for the purposes of our discussion tonight, I'm just going to focus in on diabetes specifically. Any questions about this? Actually, I'm going to point out one other thing that kind of came up when I was thinking about it from the conversation that you had earlier. You look at line 8. You have one member who has hereditary angioedema. Just their medication cost is over your high cost claimant threshold. So I just wanted to point that out too, that, all it takes is one member with one drug to make those costs go up. So just thought I'd point that out too, since it came up earlier, but I'll stop. Did somebody have a question?
Any questions? No questions, just a lot of shocked faces.
And that's actually that the costs in that space and that for that condition have actually gone down. It used to be that we had one medication for prevention in that space, and it was probably twice that. Now we have several. So Tax Zero is actually the name of the medication, and it's actually less than what we would have spent previously. And so, you know, I don't, that's probably doesn't help. It's still expensive, but it could be worse. It could be worse for sure. So, okay, so let's keep moving here. Let's look one more level down and look at some of the drugs that are in, these are your top 10 drugs by cost. So again, you have, out of 10 drugs, you have 3 of them that are diabetes drugs. And, if you recall back to the slide that we looked at before, where we talked about those drugs that we prefer because we have the best evidence, 3 of those are these drugs that were on that slide. So Trulicity, Ozempic, and Jardiance are all for diabetes. So again, just very important to keep in mind that, yes, we're spending a lot in diabetes, but if we're going to spend the money, these are the drugs we want to be spending them on, right? That's kind of how I try to look at it, because what we're going to do, hopefully, is prevent those longer term outcomes that can come, that can creep in on the medical side. All right. And then I think I have one more slide. This last slide, this is just kind of interesting, and certainly you can take a look at it in a little more detail if you'd like, but I kept it in here because we were talking about diabetes and because I just thought the numbers were kind of interesting. So if you look on let's start in the center. So if you look in the center, these are your common patients. So these are the patients that were on the plan in the prior period and they're on the plan in the current period. So they were on the plan in 2020 and they stayed with the plan in 2021. If you look at the left-hand side, those are dropped patients. So those are patients that were on the plan in 2020 but were not in 2021. And then on the right-hand side are current new patients in the current period. So not on the plan in 2020, joined the plan in 2021. And if you look, the numbers are pretty similar, right? So you lost just over 17% of your diabetes patients, but you gained just over 17% more diabetes patients. So if you look at the prior period versus the current period, you're about at 17% of diabetes patients. So a little bit different population, but overall, hopefully what that says is that your cost is relatively similar. Thing that I would like to point out about diabetes is that it is a progressive condition. So usually usually you get diagnosed fairly early on. You might, manage your condition by diet, maybe metformin. Then you're going to progress to other classes of medications like we kind of talked about. And then if, depending on how you're managing it or depending on your genetics and all those things, you may actually end up having to progress to insulin as well. And so it's very important. That's why we talk a lot about our pre-diabetes programs, and we talk a lot about managing these patients that we know have diabetes. We want to get patients in to, either disease state management or care management, or we want to be, encouraging them to stay on their medications in those early stages, because the more adherent they are to their medications and the better off they're going to be, maybe later on, and prevent some of that progression. So that doesn't happen in every condition, but diabetes that's why it's so important that we talk about this. So, and certainly, we'd love to talk about, Kelly, I'm sure has ideas about other ways we can help manage, or that we can help communicate to members important information about their diabetes or their medications. We're always available to help with those ideas or help you out with those campaigns. So I will stop there. The last couple slides are just appendix. Those are actually your top 50 drugs if you're interested. I didn't want to go quite that far into the weeds, but there's definitely some interesting information on there. So feel free to follow up with any questions if you have them.
All right. a lot of information. Anybody have any questions or concerns as we went through this that you want to bring up to Anthem while we have them on? Nope, everybody's pretty quiet here.
I don't have any questions.
I know. Did I I can't see our eyes glazed over.
They're just taking it, but Jeff has a question.
I don't have a question.
Oh,
I just
yeah,
wanted
sorry.
to say thank you for providing all this information. It's really good information. Thank you.
Good. Yep. Happy to. Thank you for having us.
I appreciate it too, because was one of the things that we've heard, some of us in the field, as we went to a new insurance, was meds changed. There was concern about doctors prescribing and doctors not being able to get what they prescribed. And so it helps us to be able to go out and speak to that when we hear those concerns, if we understand the process too. And it's something we haven't done in a couple of years, so that's why we asked for it to be done again. So I really do appreciate the presentation.
Of course. Thank you.
All right, we're going to, I'm going to reverse the agenda a little bit, and we're going to move up 2.07 because we were doing the formulary, so we might as well talk about 2.07, presentation, discussion, and possible action to introduce Ingenio RX Cost Relief Program as a new benefit program. And this is for possible action. So I'll turn it over to whoever's presenting.
Yep. So I'm going to introduce Jim Thorne. He's our pharmacy account management on the Anthem Ingenio side. So Jim is going to give us just a really quick overview of cost relief. We didn't want to get too in the weeds. We know we have a lot on the agenda this week. So really wanted to introduce this as sort of a concept and something to give you guys to really sort of mull over. And then I think in speaking with Laura, we can certainly take action today, but we would love to be able to come back with some additional data, maybe some numbers, and some practical sort of approach to how this could potentially roll out if it's something that Washoe was interested in. So I will turn it over to Jim for an overview, and Jim, I'll chime in as needed. So thank you.
Thanks, Kelly. Good evening, everyone. Jim Thorne again. Just introducing myself as your pharmacy account manager for those that don't know me. And obviously, they narrowed this down to one slide just to give you that high-level overview. But basically, it's a program to help with the specialty drug spend that you incur every year. It's a program called Cost Relief, as you can see here. And basically, what it does is it really benefits those folks on the PPO plan. You can kind of see the footnote on the bottom right there. We don't recommend this for HSA plan designs, mainly because of that first dollar coverage that folks would get from this particular program. But kind of the synopsis is we take these patient assistance that is supplied to members for specialty medications. Not every drug gets some type of patient assistance, but the majority do. With those dollars that come in, as you can see here, it says you can save up to 25% on your specialty drug spend. That's kind of a good round number, but basically it probably comes in somewhere around 10 to 15% of your specialty drug spend. And what really happens is under your current benefit on the PPO plan, instead of folks kind of paying that $50 copay, they actually would be reduced to a zero cost share for their specialty medications. So they actually get a lower out-of-pocket cost. But what we do on the back end of that claim processing is we take those specialty assistance dollars that are approved for each of those specialty members, and we kind of change their cost share. And kind of an easy example of that, which you can see here, about 3/4 of what's out there in copay assistance today in this specialty space is it's not really utilized because of cost benefit designs. So as we take that $50 cost share that members would actually incur under your current benefit, say if a member is allowed a $12,000 patient assistance for their drug, we'll use Humira because that's the number one drug in your drug spend and pretty much everybody else's. When we look at that particular drug, if a patient gets $12,000 in patient assistance, under this particular program, you're still what happens is instead of that $50 cost share for a member, we raise that cost share to $1,000. So just for ease of numbers and my math at this late hour, this is how I'm going to do it. We basically say, instead of charging you, say, $1,000 for that medication, and the member only gets charged $50, we raise that cost share to $1,000, and we take all of that copay assistance money, again, $1,000. So we're actually reducing Washoe County's plan spend for that particular medication. And obviously everybody else under this particular program. But if we use that, again, I'm just going to use flat numbers, $1,000. Today, the members are paying $50, or your associates are paying $50, and you as a plan are paying $950 of that $1,000. If we input this program into Washoe County's benefits, the cost relief program, and we get that $1,000 every single month, what's happening is we're going to reduce the member cost share down to zero from that $50, and we're going to change your $950 out of pocket and actually reduce it to zero, because we're using all of that program assistance or patient assistance dollars for those claims. So what it does is it reduces the member cost share, and it also reduces Washoe County's plan spend throughout the year for all of those members that are affected by this program. So that's kind of a high level overview with just a little bit of a little sample of what those dollars might look like. It's going to be different for every member and every drug, but that's just kind of a really quick high level math equation on how those dollars would work. Typically, again, I think you would see probably somewhere around a 10% savings or so on your plan spend throughout on an annual basis, I should say. I'm going to kind of stop there. Again, just a high level overview with that math equation. I'm sure Kelly might throw in some comments, but that's kind of how this program works. It's very easy to implement. We make outreach to all of the members. We can give you a lot more information and data as you kind of talk through this as a group and a committee. But I'll kind of stop there and let Kelly jump in.
Yeah, I think, Jim, great job on the summary. I know it's hard with just one slide here, but really this program is nice because it not only benefits a member on the PPO plan to give them a $0 cost share on a specialty drug, but it also is going to help on the back end plan spend for Washoe County School District. So we're actually using those copay assistance programs or manufacturer coupons to lower the overall cost, both from the plan spend and what the member has to pay. And that's how we're getting that 10 to 15% savings overall. Both member and plan get to share in that savings. So that's why we're introducing this as a potential option to be able to roll out for Washoe for 1/1/2023. I think somebody had a question. I'll stop there.
Rachel?
So this is Rachel Drake. So if I'm understanding this correctly, what we're talking about is we're talking about authorizing Anthem to access manufacturer copay assistance programs on behalf of our members so that those funds can be used to reimburse basically prescription drug costs on the front end. So my question then becomes, if that's what we're doing, does it only modify that copay for certain members in certain situations, or do we say all specialty copays are zero?
In most situations, Rachel, it's going to modify it for all of those members that have this type of patient assistance. More than likely, they already have this patient assistance. We're just unable to, because of your benefit design, take advantage of those dollars.
Okay, but it does only apply to members in certain situations where they have access to these funds, and we're authorizing access to, or we're authorizing Anthem to access it on behalf of our members.
Right. Typically with any carrier, when you have some type of patient assistance, the specialty company who is actually dispensing the medication already has that set up as far as the assistance program. And what happens today is it'll run through the benefit as it is. And then any dollars that come in from that patient assistance, no matter what they're approved for, just kind of apply to that current $50 cost share for members on that PPO plan. What we would be doing is just taking full advantage of those dollars. And anyone who is not, who cannot participate in the cost relief program because their particular medication, there's about 5% of the specialty drugs out there that don't participate in this program. They continue just to utilize that $50 copay or cost share.
Yeah, so we wouldn't, to your point, Rachel, we wouldn't, if somebody didn't have the copay assistance available, we wouldn't make them pay the $1,000 or whatever it is, right? We wouldn't change that. They would keep their same benefit as what they're paying today at that $50 copay, knowing that we're not getting any copay assistance. So it would only apply to the drugs that are within the list that are participating, and for those individuals on the PPO plan.
Okay, thank you. That's the first question. Unless anybody else wants to talk about that one, I have a second question. Okay, so second question then becomes, if we are not accessing this for the small percentage of our members who are on an HSA program, then the expectation is that those members are still pursuing those copays on their own, and they have that option to do so.
Correct.
Okay, thank you.
Correct. They would still, either plan, when they're on a specialty medication, more than likely they have some type of copay assistance. So that would still continue as is on the HSA plan.
Thank you.
So no changes there. Yeah, you're welcome.
Any other questions? Eric?
I do have a question about how many individual members are accessing IngenioRx. So my question is, if we were to consider a plan like this, how many individual members are we affecting? Realizing that some certain members may actually have multiple prescriptions through you, but how many members is this affecting?
It's approximately 100 at last glance. Certainly once we get a little bit further into the first quarter, we can pull some more current data, but that was the last glance at it was around 100 or so.
Other questions, Laura?
No, I was just going to make the comment that, so the intent of this was to not melt brains tonight and just to give an overview and get a temperature read of if we want to bring this back. Therefore, we can grab, more concrete numbers for you at that time as well and present it a little bit longer. Because I felt like presenting this tonight would be a lot on top of everything else we're doing. Mm-hmm. We have time to implement this program. It would start in January of next year. So it's good to start the conversation now around any other type of benefit changes we may perceive for next year.
Jeff?
Thank you, Laura. I appreciate that comment. Consider my brain melted on this. I'm not quite following. I like that it saves members money and the plan money, but I would need to see examples and maybe if we have our 2021 cost, if we had done this, what would that have been?
Yeah, absolutely. So now that everybody has had an overview, feel free to email me on an individual basis if you have any direct questions or something you'd like to see Anthem bring back, and we certainly can work on that when we do bring a full presentation. I can't exactly promise it will be our next meeting, but it will most likely be early sometime this year so we can continue the conversation.
Rachel? Oh, sorry.
So, my one question, which I'm kind of surprised didn't get addressed yet, is, gee, this sounds fabulous. It saves us money. What's the downside?
Well, and I think that's a good question for when we have this presentation.
Okay.
Yeah. So, because this was the fifth, 5,000 view. So, but I definitely have the same question. So, Tony,
that was my
your
saving money always sounds good, but what's the downside?
Right, and I wrote in my notes there was a presentation done. by LLP one time about that, the front side, the back side, and I'm going to ask them to also be here for that, this presentation to help us out. Eric?
I think that there's plenty of interest, and I think with a full presentation that would definitely satisfy a lot more of our answers, our questions with answers, because I do engage in JNURX, and I kind of want to understand exactly how this is going to affect the member as a benefit as well as the system as a whole. And I think with full examples and a full presentation, I think we'd definitely benefit from that. So thank you.
I absolutely agree. Just so you guys know, when Jeff Bozza said he kind of melted down, I'm not a number person. He is, so it made me feel better. Because I was like, how does that work? And I also use Ingenio, so I'm curious too with the effects of it. So I think that's a yes, we would like to do a future presentation on this program. So we will move it to a future date. Does that sound good with the committee? Okay. Was there anything else you wanted to say before we moved on from that subject?
No, that's great. I appreciate all the feedback, and certainly we'll have a lot more slides to melt down your brains at a later date. So
Thanks.
sure.
All right. So we're going to go back to 2.06. Presentation and discussion of the Washoe County School District Group Insurance Claim Appeals Experience Report as of November 2021. For information discussion only, this was also an issue brought to me by a member of the committee.
Perfect. So this is Kelly for the record. I will handle this. Veronica, if you want to pull it up, that would be awesome if you want to share, and I'll just tell you next slide if that's okay. And if not, I can pull it up too.
Looks like we're there.
Awesome. Not seeing it quite yet on our screen. Are you guys able to see it? It's not popping up on the Teams. I can just pull it up on my computer and walk if you guys are able to see it on your end.
It should be shared. Can you see it now?
Oh, sorry, you're cutting out just a little bit.
I'm sorry. It is on the shared screen, so I'm wondering if you can see it.
Perfect. Yep, now I can see it. Thank you.
Uh-huh.
Awesome. You can go ahead to the next slide. Perfect. So we're just going to do an overview of the appeals process, sort of talking about the level 1 and the level 2 appeals. We'll walk through kind of how it works when a claim is denied. And then we do have some data from 2020 and through November of 2021 to be able to share specific to Washoe. So for appeals, we have two types. There are pre-service appeals as well as post-service appeals. So pre-service would be you have a scheduled surgery, you're going in, it needs to be authorized, to meet medical necessity and clinical criteria. So that review is happening prior to you actually having that service done. So it's before the claim has come through. That would be pre-service. Post-service is, think of this as an emergency situation. Maybe you go in for an appendicitis and you need to have your appendix removed, so you get admitted to the hospital. You're obviously doing that sort of real time. Doctors are not going to have time to call in and do an appeal or a review at that time for that authorization. So after the benefit has come through, the claim has been paid, that would be called a post-service review. So that's pre and post, just a difference there of how those claims can come in. So you have a claim comes through and it's denied. So if you receive a denied claim, initial step to be entitled to a full and fair review.
Sorry, we lost you right after you said, if you received a denied claim.
Oh, sorry. If you receive a denied claim, you'll actually get a written notice of that denial, and that's when you're entitled to a full and fair review of that denied claim. So When the denial happens, the claims administrator, which is us, we will satisfy all of the minimum requirements applicable under federal law and regulations. So we are held to legal requirements as we review denied claims. Questions on this first slide here? Otherwise, we can go to the next one. Perfect. So if a claim is denied, oh, go ahead. Is there anything? Okay.
Nope, you're good.
Okay. If your claim is denied, you can appeal it or your doctor. In most cases, a doctor is going to appeal it on a member's behalf, but a member can call in and appeal their own claim. You would submit your appeal letter referencing the claim directly back to Anthem, and then additional information and documentation can be presented. So oftentimes when we see a denied claim, it's because there's missing medical records. Maybe a surgery has been requested, but we don't have proof that certain x-rays were done or MRIs were done, or it meets the medical criteria and clinical guidance to be necessary to have surgery as that next step. A lot of times it's just because we didn't get those records in from a provider. So at that time of the appeal is when a doctor can provide medical history, medical records for our clinical team to review to be able to make a determination on that initial appeal. The denial is based on full medical judgment. We look at whether the treatment is experimental, investigational. We base it against clinical criterias written into the plan. And we will consult with the actual doctor and other healthcare professionals that are trained in that field and that medical experience. So it's not just somebody, a layperson off the street reviewing medical records. It's clinical physicians, board certified doctors that we have on staff that go through this appeal process and actually have these conversations with your doctors who are appealing at a first level. So that's how that first level appeal process works. So that's level one. Any questions on that process that I can answer for you before we move on?
I'm not seeing any. We can go to level
Okay.
two.
Scroll down to the next slide. Oh, mine might be frozen on my end. Oh, there we go. So second level appeal. Again, as I mentioned, we have the first level appeal, which is internal within Anthem. It's using the Anthem clinical team against Anthem clinical guidelines. Is upheld, meaning we still are denying it even after getting medical records, updated information from a provider, or having a conversation. A member has a right for a second level appeal. Washoe County School District uses Maximus Federal Services for your external appeals. This is an independent organization. They have clinical and legal expertise. They don't have any association with Washoe or with Anthem, so we would call them a third-party unbiased opinion. All of the documentation on where to submit that second level appeal is housed in your SPD, and I know that the risk management team can provide that if a member should need to go through with a second level appeal. I didn't put the address and information in here, but that second level appeal is available to anybody who's had a claim denial upheld by Anthem. You can progress to the next slide. And as we're doing that, with the second level appeal, if Maximus overturns it and they approve it, Anthem is notified, and then the service can continue as it would have. We would take their approval as the approval needed, and we would go forward with processing that claim, whether it was pre-service or post-service. So again, that is the overall first and second level appeal process. Are there other questions, anything I didn't hit on there? Otherwise, we can talk just a little bit about the appeal reasons that we see for Washoe over the last 2 years.
I think we're good to talk about reasons.
Awesome. So you can see 2020 and 2021. Again, as mentioned, this is not full year 2021 as far as the data. This was through November, I believe. But in 2020, we have the appeal reason listed on the left-hand side. The top appeal reasons were surgical procedures and deductible. So somebody asking or appealing if something applies to their deductible or not. And then surgical would be those individuals who had or requested a surgical procedure that was denied because it didn't meet clinical guidelines, it wasn't medically necessary, maybe medical records were missing, or there was other appropriate treatments to try prior to an approved surgery. So that was the top two reasons for denials in 2020. There was a total of 66 appeals in the 2020 year. That was the first level appeals. And then looking over at 2021 through November, the top reasons were for inpatient admission. So the request for a patient to be admitted inpatient to a hospital would be denied because we believe that partial hospitalization is appropriate. Outpatient is more appropriate. There's a lower level of care that meets the medical guidelines. That's why we would deny an inpatient admission. So just for the benefit, we know an inpatient admission is going to be the most costly both to a member as well as the plan. When looking at clinical guidelines and what meets medical criteria, if somebody is going into the hospital, we are looking to try to keep them at the lowest level of care. We know if once you get admitted to a hospital, your risk of infection, your risk of sepsis, all of these other things start to increase, right? So if we can keep people out of inpatient admits, that's the goal. Obviously, when somebody needs in, that they'll go in and that gets approved. But a lot of times, a lower level, like an outpatient or a partial hospitalization, is going to be more appropriate. So we had 11 of those for the 2021 year. And a total of 74 appeals through November for 2021. So that's sort of the appeal reasons and the numbers that we saw. Any questions on this page that I can answer?
I just want to confirm this is level 1, correct?
Correct.
Okay. Any other questions? Okay. We can go forward.
All right, we can go to the next page. So this is just a summary of what we talked about so I misspoke a little bit there, Dunn. So it was 66 appeals. Of those 66, we actually had one in 2020 that went to Maximus for a second level of review. That denial was upheld. So Maximus agreed with the initial determination made by Anthem. That denial was upheld for 2020. And then for year-to-date 2021 through November, the 74 appeals, again, we've had one for 2021 that went to second level to Maximus. And again, that appeal was upheld, and the decision to keep the denial was confirmed. So that both of those that have gone to Maximus have had that same outcome.
Rachel.
And that was, yep.
So, so in looking at these numbers, I don't see numbers of appeals that were successfully reversed, that the denial was.
Sorry, Rachel. The microphone is breaking up a little bit. I'm not quite getting what you're saying. I apologize.
How many of these appeals were successful in reversing the denial?
I did not include that. I can certainly share that back with Laura, what our upheld versus reversal decision was. I'll take that back as a takeaway and get that out to Laura to be able to share with everyone.
Thank you.
Yep, absolutely.
Well, I guess I want to confirm, if I'm reading this, that only one went to the level 2 in 2020.
Correct.
And it was upheld. So there would have been no that were reversed in 2020 because only one went to that level 2.
So only one.
Yeah.
Yeah. So, but we would have level ones that
You're
can
talking
be
about the level 1.
up. Yep, that can be overturned.
Okay, so it's at the level 1. I understand. Any questions about level 2? As someone who's actually served here with this guy a long time, and Eric, we used to do appeals before that was removed by federal law. one a year was about our average, I would say. We didn't have many more. So this feels very accurate and moving forward. And that's what we wanted to make sure, because we don't see those anymore. So we don't know when our members were having issues that had to go to that. So that was the request to come here and bring those records to us. But Eric.
Perfect.
I think just making an open comment on this in particular, obviously having just singular appeals that are upheld in both 20 and 21 speaks to your company's relatively sound decision making, it seems like. What I think is important for us to get, though, is if any of these are being overturned at the level 1 status, just understanding that maybe it was additional information, or that, that a fair, hearing is being made for all of our members, I think is what we're getting at.
Absolutely. And I'll share those numbers. So of all those level ones, I'll share for 2020 and 2021, which ones were overturned. And I believe I can get the reason. In most cases, almost every appeal that I see, it's because we've gotten additional missing information that our clinician then is able to say, oh yeah, exactly. That diagnosis fits the clinical criteria. The inpatient admission is appropriate, or whatever the appeal was. So I'll provide that context as well. I'll get those numbers for you all, just so you have some idea of those that are overturned and then get approved for a member. And included in that level 1, and this isn't in the slides, but included in that level 1 is something we call peer-to-peer. So most times when a provider appeals a decision, it's via email communication. They provide additional records. They fax them into us or email them into us. The clinician reviews, and then that decision to overturn and allow that claim service is notified. So member gets notified via a letter, as well as the provider. A lot of times, not a lot, often, or once in a while, I guess I should say, a provider will request a peer-to-peer, meaning they just want to get on the phone, peer-to-peer, talk to a physician within the Anthem system, explain the rationale, explain the medical history, and so we can have an actual peer-to-peer with a provider and then make that decision there. So most of it happens via mail, fax, but once in a while we will have a peer-to-peer where the physicians will actually get on the phone and chat with each other to review that clinical information.
Any other questions?
I was going to add one thing to what Kelly said. So if they do a peer-to-peer and they're not able to approve it, that doesn't take away any of their appeal rights. So they still have both the first level and the second level appeal. So just one other important thing.
Thanks, Bridget.
Thank you. I think that's really good information for us today, and I really appreciate the presentation. And we'll look forward to seeing on the first level how that all went, so we can.
Perfect.
So, anything else for Anthem? Well, I want to thank you for being here via Teams. I wish you had been here in face to face, but we'll look forward to that day soon when we can talk about the other presentations coming. So, thank you so much for your presentations today.
We couldn't be there in person.
Thank you.
All right, moving on. 2.08, presentation discussion, possible action to change the Washoe County School District group insurance 90-day benefit waiting period for new employees. For possible action, brought to us by a committee member. Who's presenting? Is it discussion?
It's a discussion. I can
Okay.
Okay, it was, as far as I know, this is a discussion about potentially decreasing our 90-day rate, right? And so I have gathered some information, but I also wanted to hear from committee members on their thoughts. I've spoke with Lloyd with LP and Kelly with Anthem to kind of get a temperature of the current industry standards. I've been with the district for 10 years now. I know a lot of us have been here a long time, so I don't know anything different really than 90-day. It sounded normal to me, right? It does sound like, in general, over all types of industries, private and public, right, that the the trend is going away from a 90-day. The 90-day is still there for a lot of companies, but it's more on the longer end. That being said, when looking at different entities, it's kind of all over the place what people do. There's not an exact number, I would say. Lloyd did bring some good information to me, kind of showing the public sector, the average is about 1.3 months wait currently. So the way that's determined can be lots of different ways. You see entities starting benefits first day of their contract or first day of their work, right? You see entities 30 or 60 or 90 days. Sometimes you see it first of the following month after 30 days of work, first of the following month after 60 days. So it can get real complicated too, and it could not always be the exact time frame for everyone as well when you do that, depending on when you start your work, your contract or your work. So I'm not here to recommend anything to the committee today, but to kind of start the discussion. One thing I want to be mindful of when we're talking about this is our actual processes of how we implement our benefits in the district, meaning how the logistic portion of it. We currently have 2 employees that process all of our benefits, and all of that is data entry into our current Business Plus program, which is our internal district program that helps run the payroll and the benefit packages within our district program, and they also enter into the Anthem portal for all the data there, amongst other things. So when we're looking at that, initially I'm thinking in my head, there's no way we're going to be able to successfully implement something in a very short turnaround with the number of employees that we have coming in on a new hire basis every year, specifically usually at the beginning of the school year with our large hiring of teachers, which can vary from year to year, but I would say on average, a couple hundred new teachers a year is what we look at. It can be lower, it can be higher, depending upon the year. And that's just generally our teachers. So then we have other individuals, obviously, beyond that. So our school year starts, I don't know when it starts, this August. It's August, but I can't remember the exact date. What we see once the information, I feel like I can't be heard very well, so let me know if I'm too loud. But once HR, we're part of HR, but the HR techs that actually process all the data, background, everything, once that information gets in the system and that information gets to us in benefits, we're seeing that information coming in middle of August, sometimes middle of September, and that's average. So we're not even getting some of the information to process benefits until after people are working, usually. One cool thing that we've been working on for a while, and we're really trying to get up to speed and test here soon, is we are doing a new hire portal that we've been building. Our office has been building with our IT department. So ideally, this portal is going to be able to make our processes somewhat more efficient. And on a high level overview, I guess what it looks like is once the person is hired and they're in our Business Plus system that's input by our HR representative, it triggers a secure email to go to that individual to sign up for their benefits through an online portal. So some of that, once this happens, cross our fingers, we'll cut down on some of our data entry and hopefully cut out some of that time frame as well. We will be sending secure files for information to Anthem, but we don't have a way yet for that to connect to our Business Plus, meaning our payroll and the benefit packages within there. So there's still going to be some data entry, and we're still going to have to look at that time frame of when can we actually implement benefits then in Anthem, and when are those contributions and deductions for our health insurance premiums going to actually affect the paychecks? Because we want those to align. If we can't get Business Plus to work fast enough or to link up with those packages, it might not matter if we can get the information to Anthem sooner, if that makes any sense. So I'm just telling you this to give you this background information, telling you we're trying to make our processes more efficient. But along the way, I think when we have this discussion, we want to take that into consideration, because if we end up going to something that's lesser than 90 days, which would be an amazing benefit for some of our new hires and attracting some qualified professionals, we want to make sure it's also successful too, and we don't create more frustration with the already busy and hectic new hire process that they're already going through. It's overwhelming as a new hire in any company, so we don't want to make that worse. So I'm not telling you this information to sound like a Debbie Downer. It's just kind of our realistic situation right now when we have the discussion. But other than that, I'm open to questions or any comments, or if you want to discuss where you think you want to see us go. Yeah.
Robert?
So when I got hired with the district, it was 90 days, obviously it still is, but I continued to work at my job at Rayleigh's through November, and it still ended up a couple of weeks without insurance because my insurance benefits hadn't kicked in yet. But I was young and I wasn't all that worried about it, but I did continue to work at my second job and work 2 jobs for the first 3 months simply to keep benefits. And I wonder how many people, I mean, like I said, I was out of college and I was young, but I wonder how many people who are coming in as a second career, who have dependents, who have kids, or, coming into other job classifications, and they're leaving businesses to be a bus driver. They're coming in for other things. They can afford to go 3 months without having insurance for them as well as their kids, especially if they have prescriptions and things like that. So my concern really is, if we can reduce that, it will help with hiring, especially in other job classes, I think. Even if it was like a 30-day window for us to process and get them lined up with something, that it would be better. And, honestly, I think with teachers and stuff, we sign a year-long contract. That doesn't mean they all stay, but most of us are going to stay for the year. So it's not like we come for the benefits for a month and then we go and find another job.
Can I add to that a little bit? You want to go?
Yeah. Tony, Mike, go.
Yeah, I'd like to add to that point, Robert. And I did bring this up a few months ago, just because this school year I had 2 principals approach me with this question, and I didn't know. And as I have asked around in a little conversation we had, the response to the 90-day was that they didn't want to provide a benefit to somebody that's going to leave within the first 90 days. So my response to that was, well, that I could understand that in some sectors, but principals and teachers, so our licensed staff, we all agree to a 1-year contract. So in regards to the principal component, those principals, to your point, are current in-state Nevada principals trying to relocate to Washoe. So we all know to take the risk of 90 days without insurance for your family is a tough one. And I didn't take the next step to really research it, but they claimed that other districts in the state don't have a waiting period, that you could have transferred over pretty quick. And maybe it was a 30-day, but it was definitely not a 90-day. So I think another point to add to your concern about processing, I'm pretty certain our admin contracts run July to July. Teachers are August to August. So there's a little bit of a buffer. There would be a buffer built in there if most principals are coming on the start of the fiscal year in July 1. I don't know if you know about that. You'd have a month there before the teachers came on. Their contracts in August. Are you guys August? It is July for both? That did change a few years ago. Yeah. So I'd be curious, too, to hear what a few of you others think that have different bargaining units, how that would affect yours. But I wonder if with the licensed staff, there couldn't be some conversation of reducing it if the fear is those folks tend to exit within 90 days, because I don't think that's a realistic concern at this point. And I do think it could help with recruitment for all of our licensed positions.
Tony, and then Eric.
From an APTA perspective, we're, 250-day, all year, hire anytime. I mean, we're all the time. So the 90 days, July 1st, August 1st, January 15th, doesn't matter, much like the West people in that. Same thing, the majority. And I hear what Laura's saying. We're all tasked with a lot. My question is, there's a cost to the district that isn't being expended for that 90 days. And an employee has the benefit of COBRA with their previous employer. Could a portion of that money that the district is saving, because they're not paying for insurance for the 90 days either, go to the employee as maybe a COBRA benefit, a certain amount? That would help with the existing, getting it in the system and everything else, but still providing the ability for an employee to get insurance. That's for an employee and not a dependent or anything, but a possible solution that, at some level provides a little bit of benefit if we needed a full 90 days to get in systems and in those type of things.
So we can certainly look at that and see if there's other numbers, and I could maybe have that discussion with our business office as well. So the district contributes the employee contribution during the 90-day wait to our health insurance fund. So if we looked at something like that, we would want to take that in consideration, that we could potentially be taking away from that revenue for health insurance fund. That's a new concept. So I have to wrap my brain around it a little bit more and give it some more thought and see, but that's would be part of that.
Can you repeat that one more time, the first part?
So during the 90-day wait, the district contributes the employee contributions. So there's, I'm trying to think of the easiest way to explain this, but the district pays for our insurance as an employee, right?
So they're already paying for it, they're just not getting the benefit. It's short terms for the 90 days, is that what I'm hearing you say?
So the contribution that the district pays for us as an employee, we pay zero, but the district pays, right? That goes into our health insurance fund.
Right.
Yeah.
Gotcha. I did not know that.
Okay.
And so I just want to remind the committee, this is our discussion where we're going to give Laura all these talking things to go back and research. So we don't expect her to have perfect answers today, right?
Yeah, I won't
Just
have
wanna-
perfect
I
answers.
just want to put that out there. Eric?
My initial thought on this is that it's something that's attractive. Obviously, I'm cautiously optimistic. I want to understand what the risks are to the insurance committee as a whole. Just as you were saying, like the idea of paying that in, or what, the 90-day standard. I've never understood that myself. It's just not my field. I just figured it was an industry standard. So if we can understand if we give that up or reduce it, what is our liability or what is our loss as an insurance system? Otherwise, on the positive end of this conversation, I actually find that I have a lot of appetite for it, only because I see it's an incredible incentive to our recruiting issues, specifically in my field, and I think what you were speaking to as well, that as a licensed police officer, we don't go anywhere. So at least for my particular bargaining unit, there is no, I don't see any risk in offering that as a benefit to a new employee. Because there's very little to no possibility of that person leaving. But I am interested to know, like I said, the unknown risks as an insurance system as a whole. What is it that we risk by reducing that from 90 days?
I would ask for that at different levels. 90 day, 60 day, 30 day maybe.
Okay.
Not like as a whole, like wipe out the 90, but there's a 30-day risk, there's a 60-day risk or something of that nature.
And I'm just going to add to the record, as someone who did medical billing all through college and then somewhat into this career to make some side money, the fear of someone leaving the insurance company seems to shut that down pretty quick once a person has left the district, because we would get immediately, this person's no longer employed if they were one of our patients. So it seems pretty fast that comes from the insurance company, a denial that because they're no longer employed.
So I want to keep in mind that we are the insurance company in this situation. So we, meaning our office, are the ones who are actually doing that. So just like oncoming new hires and getting information on a lagged point, and this is, it's not like it's necessarily wrong or bad. It's just how the information comes across. The same is with terminations. So we're oftentimes backdating terminations because we get the information later. So if you think of it like at a site level, and all sites work differently, all 100 some, sometimes, somebody doesn't report to work. HR doesn't find out about that until a month or two later. So that person hasn't had a paycheck. We should have term benefits, that type of thing. That is not an uncommon event at all. So it works on both sides. We do it as fast as we can because we don't want to incur any type of claims and have any type of issue, but we are looking at those types of things on a daily basis. The other thing to consider, I think, is that when you sign up for benefits, you have that option of signing up dependents. And our plan currently is written that if you don't sign up within your 90 days, you still have the option to enroll, and your enrollment would be that first day of the following month of when you do enroll, but you don't have the option to add dependents. Okay, so by cutting our time frame again, we might be squeezing out some of that. I don't want to say opportunity because it's still going to be there, but we have many late enrollees, even with 90-day. People forget about it or whatever it might be, and then the good thing is we get to continue and enroll ourselves, but we can't enroll our dependents. That is actually a great benefit that we have at the district. Most companies often say you can't enroll at all. You have to wait until open enrollment. So that's another thing to consider, is we want to be able to give the opportunity for people to have a little bit of lag time to actually enroll.
Rachel?
So I am hearing that we do have support for gathering more information about what the management costs are actually on this, because it's sounding like that's going to be the thing that we would have to incur, because with the money's already being donated or already being put into the employee health account and those sorts of things. Some of these pieces are already there. And one of the reasons that I really want us to consider reducing the 90 days to something like 30, 60, if that's where we have to go with it, is because yearly I am referring employees to free clinics because they've gotten sick, they have medical needs, and they have no insurance. And this is something that I do at one small little school, and it happens every single year. It happens with our ESP staff, it happens with our teaching staff. I've never had to do that with an administrator, but I've seen it happen at many other levels. And for us to be able to say, hey, come teach our children, all of these little sick, germ-infested children, and put them on buses and deal with their snot and all of those sorts of things, and know that the largest reason any of our new employees miss work is because they're sick. And for us to have an opportunity to make sure that they have a little more coverage and a little more surety, I think is something we absolutely have to consider.
Thank you. Yes, Jeff.
So I'm also interested in looking at different periods, 30 days, 60 day. But earlier, Laura, you expressed concerns about having 2 staff members. So I think we'd want to take a look at what your team can realistically do, so that you're not in a bind if we say like, oh, it's going to be 30 days and then we're not able to make it.
Yeah, and I can certainly bring some more of that information back in terms of our staffing and numbers and things like that. And I will say that I did speak with Lloyd on some of the numbers, and I don't if you would like to come and speak, you can, Lloyd, but
Would you like to join us?
I also want to set realistic expectations of what type of numbers we can or cannot bring back. I am not sure we'll be able to meet the expectations of the 30, 60, 90 days in terms of loss, but Lloyd has more experience in seeing this, and I think he can speak to it a little bit more.
I always want to come speak with you guys. Lloyd Barnes, LP Insurance Services, for the record. So everything Laura has laid out for you guys is spot on as far as this particular topic goes, and your questions have been very good, appropriate. The general school of thought is the less turnover you have, an organization has, the less risk this is. Because the risk is really just the person who gets insurance and leaves while having insurance in a way that they wouldn't have if there was a longer waiting period. So again, whether it's a 90 to 60 or 90 to 30, the risk is that little window there. It's not going to be possible to give a financial estimate as to what that looks like, because we don't have a population that is in that window, because you're already at the 90-day place. Now, about the only way I could possibly think of is if you could look, if you had the ability to look at the number of employees that term between 60 and 90 days, and we took an average cost per person of X times those body. I mean, that might give you a little bit of an idea, but it's going to be a real loose estimate from that standpoint. So that would be my concern, or not my caution to that type of an estimate. You're going to be talking very minimal dollars, because the number of people that don't last in that little window is going to be, and you might have 2 in a year or something. The converse to that is, one of those people could go out and run up a $100,000 bill, though. So that is the risk in that type of a situation. Personally, I think it's a relatively low risk. I think this, to me, as Laura said, we are seeing more and more employers, especially in this challenging employment environment, pushing their waiting periods down from 90 days, those that did have 90 days, pushing them down to 60, 30, first of the month following 30, things like that. Date of hire is probably that's a pretty aggressive move. There are employers that do that, but that is a pretty aggressive move that I would say is less common. I think this is an administrative consideration decision more than anything. The financial impact is going to be a pulling forward of costs, sort of a one-time, it happens sort of one time for that first year. As you pull forward that cost by 30 days, for example, people can now get care that they would have pushed off for 30 days. It's generally going to be the same care. It just moves forward on the cost on the calendar year by 30 days if that was the decision. So it's not really an increased cost. It's a moving forward of costs is how we generally look at it. So I don't know if that helped at all, but I think the real consideration is, what is going to be practical from an administrative standpoint? Are there some limits to what's really going to work? And from a cost standpoint, it's going to be a real tough estimate.
I think, Laura, I'd like to also ask that maybe we have to ask legal a question, because in most of our contracts, if you leave before your year contract is up, you owe back your sick days you took, you owe back. I mean, there could be a way for us to have something in there that helps that too, if we move up our dates, if we're worried they're leaving in the first 90 days. That's already in most of our contracts for our other things. So I don't know if that's something we need to discuss with legal too, about this part of it. I also think we need to look at a 2-year roll-in if we need to. I mean, it would be great to have a plan. So that might be a thought where we move up 60 the first, anything we can talk about. I think a lot of times what happens, we have discussions and we get a black and white answer and we don't have a plan that moves it forward. And so I think that's something I'd like to see. Mike?
Yeah, thank you. That was helpful information. I think to your point, for sure, if you separate early, I've had that happen a few times lately, they do prorate out your year and backtrack sick days and vacation days. But I'm wondering, after just listening to a little bit more of the conversation, your concerns, we all agree, and as you just said, Lloyd, hiring right now is something we've never experienced, and it's going to get worse. I think we're going to enter the hardest teaching hiring season we've ever had this fall. That being said, I do think it would be very appropriate, and I would encourage maybe our committee here could say, as a recruitment tool to HR, if we're going to offer this, your team needs more support to implement it. And looking at, if you're saying, hey, our team of two just simply can't process this amount of paperwork, as you're saying, as an administrative concern, I would propose that we say part of the package is your team needs to grow. And I think that's a very valid point. When you look at, I look today, we have almost 9,000 employees right now. And your point of even clearing out the paperwork on the termination side, that's another barrier. So, I mean, that's my thoughts right now. And I have no problem talking to, my direction of supervisors of, hey, here's a possible solution, but our risk management team needs to grow in order to do it. And if we view it as a recruitment tool, I think there could be a lot of power in that.
Thank you, Mike. Eric?
Thank you. And yes, after hearing Lloyd's input, I'm a lot more confident in moving forward with something on this, a definite reduction. Largely from a recruitment standpoint, in a benefit that we can advertise to people coming into the district, only because we're also experiencing a serious drought in decent applicants. So being able to offer a reduced period, one thing that I think is important too is that, new employees are already going to be covered for on-the-job kinds of injuries. So one thing that I would caution ourselves from doing is obviously going all the way down to zero. I'm not sure anybody was entertaining an idea to go down to 0 days. But a drastic reduction is something I think that we should definitely consider and see what our options are from an administrative standpoint, or if there's any other barriers that we're not seeing. Obviously, thanks again, Lloyd, for your input in trying to determine if there's a financial concern, but understanding too that the district is already paying in essence 3 months for an employee who doesn't have benefits. I think there's already a positive end to the financial concern that I was having. But I'm definitely a lot more confident in moving forward with this, cautiously, of course, to understand that there's a new benefit that could help multiple units in their recruiting efforts. Dawn, to your statement about contract issues and concerns, running that by legal, I think is going to be important too, because my particular bargaining unit has nothing like that. So I think it's going to be obviously handled individually per whatever contractual agreements there are that exist.
Jeff?
Thanks. So at a future meeting, if we were to take action on this, is this like the health insurance rates or any benefit change where it has to go to the board for approval and it's just our recommendation that goes to them?
Yes, it would. We would have a plan document change and we would take it to the superintendent for approval. Yep.
Okay, thanks.
Talking about plan documents, Lloyd, in our plan document, do we still have if you meet your deductible in the last 3 months, it rolls forward? Is that still in our plan?
Yes.
So
it
is there a possibility, if we were to do this, because we'd be bringing on all the new hires for 3 months, that we had a carve out on that part? Because that was the only thing I could see where a cost could be a little bit, something we weren't expecting, right? They would all be, there was a possibility all of our new employees, not all of them, but would make their plan, their deductible, and then be no deductible for the next year.
They would have that opportunity, but they didn't.
Yeah, because it would be made in those last 3 months.
I don't see how administratively we could get Anthem to do that. I mean, just I won't say it's impossible, because anything's possible. But I think just administratively, it would be pretty cumbersome to try to flag person 1 that you don't get to do the carryover, in person 2, 3, 4, and 5 they do, and in person 7 they don't. I could see that being a little too.
And I'm not
onerous.
trying to be nitpicky, really. It's just when I was looking at.
It's a good idea, but I think it would be a
cost
lot
and what
to
we could
manage.
incur.
Yeah.
That was my one thought.
Very creative idea, but I think that would be a little bit. I don't know if you get your bang for your buck on trying to figure out how to administer that.
I'm happy to give them the rollover. I just was like, I know what we look at every year when we're looking at rates. I wanted to make sure we protected too. So, any other questions or comments for our future discussion to send back with Laura?
I suppose. Beyond your personnel limitations, are there any other limitations that you would see as a potential barrier to bring this down to, let's say, 30 days?
Just the consideration that I already brought up about adding dependents, and that's more of a, it's not a barrier. It's just to take in consideration that we would have an increased percentage of people who don't sign up in time. Therefore, they would not be able to add their dependents for that year until open enrollment. It's not a barrier necessarily. It's just a consideration to take into hand. So it's kind of it's a little bit of trade-off maybe for some people. Now, if people are right on top of it, it's going to happen. But
Maybe a better word is limitation. I don't mean barrier.
Okay.
Jeff.
Thanks. So Laura, being able to add dependents after that 90-day period has expired, is that our policy or is that an Anthem policy?
I mean, yes, it's written in our plan document, but I wouldn't say it's not like it's outside of industry standard, right? And like I mentioned before, I think, and maybe Lloyd can speak to this too. He would know more on this, obviously, because he has several clients. But usually, you can't add on any dependents just until open enrollment. So, yes.
It's part of the Section 125 cafeteria plan rules for qualifying events. So basically, if you're doing anything in a tax favored way through a cafeteria plan, you have to follow those rules very specifically. The way the district gets away with it from the employee only is the employee's not paying anything. And so you allow for what's called a late entrant for the employee only. But anytime there's employee contributions, to have those be tax favored, non-taxable for their contribution, it has to follow those strict rules. So Laura's correct in that you would have to be by the book. If you did move it forward, you would have to be by the book for that window, and they would not have any latitude around that, beyond that.
Okay, thank you both.
Isn't our open enrollment like October and November, or October through December?
Yeah, this year was September 1st through November 1st, so it's a
So
couple
pretty
months.
much they would, if they missed it in that
It's almost a whole
they would
year.
start it again, right?
Yeah.
No, would
It's
they? Or
a
would
whole.
it?
They would almost wait. So if we're talking about teachers and licensed administrators that would start during the school year, in general, they do. If they miss, they need to wait until. Sorry, I'm just backtracking this in my brain. In general, currently, their benefits are going to be intact in November, early November. So they've already missed open enrollment usually, and they have to wait the next year. Have to look at timeframes, if there's some way to back that up. Logistically, it wouldn't be the best way, but maybe we could figure it out for them. Yeah.
Anything else for this discussion, Jeff?
So on the same topic, earlier you mentioned the new hire portal. Let's just say that was something that's rolled out. Could that send the employee an email every morning until they sign up, just so they don't miss on
I
that?
love that idea.
It is planned to send out email reminders. Yes, every morning. They already think we spam them, but I'll just say Jeff said.
Yeah, it just, I wouldn't want to have one reminder of, if I was a teacher and started and really busy that first month,
Yeah.
well, all months, but
Yeah.
it's hard to remember to do that unless I remember to do things, if I'm getting them daily. So
Okay.
I think that would help.
Let me ask IT if that's a possibility.
I think that's very kind.
I just think that there's so many different reminders that the district sends out for our requirements, for training, for upkeep and maintenance of our certifications. There's got to be something that we can have sent out to our newest members as a reminder. If it's spammed or if it's, time released at, you've got 3 weeks, you've got 2 weeks, you've got 1 week, you're done. I think that there's got to be something, especially within your new portal. I'm interested to see that. But if it has that ability, then I think that could be a sufficient way to say, we've offered this to you and it's no longer available. I mean, personal responsibility kicks in at some point as well.
Mike? All right, anything else on this topic? I think it's really important, and it was a good one to bring in forth. Thank you, Rachel, who got a hold of me. All right, now for the time you all wanted, and Lloyd, thanks for always staying so you knew you could answer those questions. We're going to 3.01. Any public comment?
Lloyd?
You All right, 3.02, announcement of the next meeting will be February 23rd, 2022. We will be holding elections at that meeting. So, and that meeting will be held at this point, right here in the school district meeting room. 3.03, I am going to adjourn this meeting. I have no idea what time it is, but the meeting is adjourned. Thanks, guys.